Welcome to tonight's webinar, Is it safe enough to return to campus? What do public health scientists say? My name is Terezia Zorić, and I'm the president of the University of Toronto Faculty Association, and I'll be moderating tonight's panel with its stellar cast. It is a town hall that is being hosted by the Toronto Inter-University Coalition, and we came together to share information and coordinate our efforts to advocate for the health and safety of our members during this pandemic. The coalition consists of 4 faculty associations and unions from OCAD, X or Ryerson University, York University, and the University of Toronto, and we represent faculty, librarians, counselors, academic staff, non-academic staff on these campuses. Our universities, these 4 universities, have a combined total of over 205,000 university students and tens of thousands of faculty, librarians, counselors, and staff. So on behalf of the coalition, I welcome you and thank you for attending this evening. And welcome to all the university faculty associations and staff unions from beyond Toronto and from the student sector leadership. You're all welcome. Following the land acknowledgement, I will review tonight's agenda with you and cover a few housekeeping items. At this point, I'll call upon Colleen Burke, who's the president of the Steelworkers Local 1998 in Toronto, and she'll do the land acknowledgement.
Thanks, Teresa. We would like to begin by acknowledging that the land on which we gather here in Toronto is the traditional territory of the Haudenosaunee, the Métis, and most recently, the territory of the Mississaugas of the Credit First Nation. The territory is the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. This territory is also covered by the Upper Canada Treaties. And today, the meeting place of Toronto, from the Haudenosaunee word, Takaronto, is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work in this territory.
Thanks very much. I'm now going to share my screen and just do a few housekeeping items. I noted that folks are only seeing the top of my head, so I've adjusted that. I guess one of the housekeeping pieces is that the chat is going to be a place in which you may speak with each other, but it's going to be an unmoderated space. If you would like to pose questions for our panelists or send questions or comments to the organizers or the moderator, we would ask that you use the Q&A menu at the bottom of your screen. We will continue to have ASL interpretation, and we will be recording this and taking some steps to do some light editing of it in order to increase accessibility, and then it will be posted on the websites of the various organizers. But let me begin by talking about the main purposes of this evening. Let's make sure actually I caught all of this. Oh yes, thank you very much to the more than 100 people who sent us questions ahead of time. We have done our best to combine and address those questions. We won't be able to get to all of them, but we also have some further questions for our panelists. And yeah, why don't I begin sharing my screen and talking about what the agenda tonight is going to look like. So tonight's event, of course, is called Is It Safe Enough to Return to Campus? What do public health scientists say? It will be an interactive panel, and the agenda will be like so. I'm almost finished with the housekeeping. In a few moments, we're going to invite our panel of experts to speak to you in 3 parts. In the first case, we're going to focus on epidemiology. In the second, on ethics. And the third, on the mitigation strategies. Then we'll have very brief reports from each of the 4 universities, and then we'll return to a panel question and period answer that will continue, that will involve your questions tonight, and then we'll have some closing comments. As noted, we represent 4 universities and the U of T Faculty Association, Ryerson or the XFA, UFA, OCAD FA, 3 CUPE locals, and the Steelworkers Local 1998. And we are grateful to the Ontario Confederation of Faculty Associations, or ACUFA, for its technical support of tonight's event. We are even more grateful to our expert panel. If I were to read to you all of the areas of expertise of our 7 panelists, it would take the rest of tonight. But we are simply delighted to have Arjumand Siddiqi, Ashleigh Tuite, David Fisman, initially on video, James Scott, Jeffery Siegel, Paul Bozek, and Ross Upshur, all from U of T's Dalla Lana School of Public Health, and many of them now household names during this pandemic. We are extremely grateful to these public health experts who've been extremely generous with their time. And I think that you are most eager to hear from them rather than from us. And we're going to begin to move to the questions that we've asked them to address at this point. So as I said, our first chapter for our expert panel will be with a focus on epidemiology. And we asked David Fisman, who kindly pre-recorded his answer, to address these 3 questions. What are the COVID trends in Ontario and in Toronto? Why is the prediction that we are headed for a grim fall? And what does the modeling tell us? And here's David.
My name is David Fisman, and I'm an infectious disease researcher and physician at the Dalla School of Public Health. I'm an epidemiologist primarily. I serve in a couple of roles in Canada, part of some national modeling communities, although I think most notoriously I stepped down from the Ontario Modeling and Science Tables a couple of weeks ago over concerns about politics and transparency around where Ontario is headed this fall. So I was asked to comment on what COVID trends are in Ontario and Toronto right now. I made a comment that we're headed for a grim fall, so I guess I'll try to defend that comment and talk about what sort of a commonsensical approach to this fall might dictate. So we're actually not in an extreme situation at the moment in Ontario in terms of COVID. The difficulty is we wouldn't have expected to be at this point. We do have low-grade exponential growth going on in terms of case counts. We do have intensive care units that already heading into the fall have about 20% of their COVID beds already occupied, in contrast to last year where heading into the fall, we really didn't have any COVID to speak of occupying beds in the ICU, very small amount. The reason I'm quite concerned about this fall is what we've seen over the summer is the Delta variant, a highly infectious form of the SARS-2 coronavirus, has replaced prior variants and original COVID that we had at the beginning of the pandemic. The Delta variant has a couple of really nasty attributes. Vaccines seem to cover it pretty well. There's some question of whether vaccine effectiveness is a little bit diminished with Delta. But the 2 main concerns are, one, it's much, much more transmissible. As the US CDC has said, it looks more like chickenpox than like original SARS-CoV-2. And the second is we have forthcoming work in the Canadian Medical Association Journal showing that it is actually deadlier. So we're talking about 2 to 3-fold increased risks of severe outcomes like intensive care unit admission and death. What we also see is that the relative increase in severity of Delta actually trends up with decreasing age. So for the oldest people in the population, Delta is about 1.5 times more deadly. But as you go down the lifespan, the relative increase actually goes up and up and up in sort of a linear fashion. And I think that work got a bit of press because we mentioned the fact that kids, for example, seem to be 3 times more likely to be hospitalized with Delta than non-Delta strains. What that means is that we really have our work cut out for us heading into this fall as a university community. My concerns with safety on the U of T campus really relate to occupancy and ventilation. We know at this point that this is an airborne disease. Ontario universities broadly have pushed the government to give them waivers on room occupancy. And from the get-go, colleagues in Japan said this is a disease that spreads where it's closed and crowded. I think we need to look after one another, look after our community. I just want to end off with a shout out to the faculty associations and the unions that have been working really hand in hand to try to keep staff and faculty and students safe this coming fall. And I wish you all the best and hopefully catch up with you soon.
Very, very happy to have had David's voice. He'll be joining us, we're hoping, shortly after 8 o'clock, and we'll be able to participate in the follow-up round. We will next hear from Ashleigh Tuite, who is a colleague who works very closely with David Fisman, to talk about, to answer this question. Many of us have heard that we don't need to be concerned about the rising number of COVID cases because cases have been decoupled from severe illness and hospitalization. Is this an accurate assessment of current risk? Ashleigh?
Hi, thank you. And I guess just to really quickly summarize what I think David may have said, just to sort of set the scene in terms of what we're expecting to happen come the fall. We are looking at potentially having a 4th wave of COVID that is as bad or potentially worse than the waves that we've experienced to date. And this really relates to the fact that even though we have vaccines, we also have a lot of fatigue in our population. And I would say a loss of political will to really have the measures that we've had in place thus far continue. And so if we allow COVID to continue to circulate in our population, we could see a situation where we have enough infections that we strain our healthcare system again. And this sort of feeds into the question that you asked me, Terezia, in terms of the decoupling. So one of the things that we've been hearing a lot about is that, once we have vaccines in our population, we're going to essentially defang the virus. So, people may get infected, but because they're vaccinated, they're not going to end up needing hospital care. They're not going to die of COVID anymore. And the reality is that the vaccines are incredibly effective. And amongst vaccinated people, they do dramatically reduce the risk that they do experience severe illness. But we still see this relationship between, cases predicting hospitalizations, which predict ICU admissions, which predict mortality. And that relates to the fact that we still have a lot of people who are not vaccinated right now. And as long as we have cases happening, those cases will, some of those people will end up experiencing severe illness. And when we look at the data in Ontario, and it's similar across the country and really around the world, we don't see evidence of this decoupling. And that really relates to the fact that the effects of the vaccines have been effectively counterbalanced by the fact that we have the Delta variant now, which is far more transmissible and also has increased severity. So that's really sort of counterbalancing what we're seeing with the vaccines. And so the reality at this point is that, we can't effectively bargain with the virus. Just because we're tired of the pandemic doesn't mean that COVID is done with us and is going to go away. And it's going to find its way into susceptible populations. And so that's primarily the immunocompromised, it's people who haven't been vaccinated, so children, and those who are either unvaccinated by choice or for medical reasons. And so the risk has shifted, but it doesn't mean that the virus is gone or is decoupled from severe illness.
Thanks very much, and you helped us set the stage. But I think we're ready to hear David's answer. Then we're going to loop in Arjumand and perhaps give you an opportunity to revisit from a different perspective. So the next question here, and I'll just share my screen because that may make it easier for people to focus on what's occurring. Keeping in line with the previous question, what should our primary goal be in terms of tackling COVID? For example, should our primary focus be on trying to prevent COVID-related deaths and severe illnesses? Or, bit of a typo there, or are those inappropriate ways to measure harm? What are the human rights implications of the various goals or approaches to tackling COVID? Arjumand?
Thanks very much, Teresa. Thanks everyone for having me tonight. I very much want to continue what Ashleigh was saying in that we really have quite a bit of reason to still be worried about people getting very sick, but we also have reason to worry about other outcomes that we seem to be seeing in people who have COVID infections, things that we call long COVID. Long-term symptoms that we are seeing, but we don't know much about at this point. And in previous conversations, we've talked a little bit about, in various forums, we've talked a little bit about the fact that the bar of preventing hospitalizations and deaths was very appropriate for trying to understand how to mitigate overwhelming a healthcare system, how to figure out when to open up some basic services, particularly in the healthcare system. It's not clear to me that hospitalizations and mortality and preventing those is in and of itself enough of a bar to figure out when we should be returning in person to work. At the end of the day, we all love our work, we all love our students, we all love what we do, and it's much more than a job in many senses, but it is a job. It is labor. And I think the bar for figuring out when labor should be performed that is different than the bar that we should use for trying to understand what's happening to the healthcare system. So it's important for us to understand a variety of outcomes related to COVID, not only hospitalizations and mortality, but also some of the other sequelae that we're seeing.
And Arjumand, I really liked what Ashleigh said a few minutes ago about we can't really bargain with this virus. Who do you think loses the most when we seek to manage or simply do the bare minimum? Are there some populations who pay a greater price than others?
Most definitely. And in fact, it should come as no surprise because there are populations that have been paying the largest price from the onset of this pandemic. And in fact, for almost every health outcome of which we know, there are inequalities by socioeconomics, by race, by other metrics of vulnerability and disadvantage in society. And so when the COVID pandemic happened, very quickly, we saw this same patterning emerge for a brand new illness, whereby society's most disadvantaged were the most likely to be infected, the most likely to die. And then when we had vaccine onset, we saw the same pattern, where the most disadvantaged were the least likely to have access to the vaccine. And again, we see the same thing happening. So there's absolutely no reason not to think that whatever we decide to do, the brunt of it will be borne by the most disadvantaged.
Thanks very much. And then the next question sort of follows from that same way. You serve, Arjumand, on the Ontario Science Table, as does Ashleigh. And the next question's for Ashleigh, and then there's one connected for you, Arjumand. I'm just going to share the screen. I find it helpful to see these questions written out. I hope other folks do too. What are the Ontario Science Table's most recent recommendations for tackling the Delta variant that you described earlier, Ashleigh? And why didn't the Ontario Science Table simply put all its eggs in the vaccine basket?
So I mean, I guess I'll start with the first is why are we not simply relying on vaccines given how wonderful they are? And I think, early on when vaccines first became available, when we first got the trial data, there was a lot of excitement and optimism because the vaccines looked like they were going to really quickly end the pandemic, at least in places that had access to the vaccines. But they haven't. And the reason that they haven't is because the Delta variant emerged, and that's really complicated things. It's more transmissible, it's harder to control, the vaccines are less effective at preventing transmission. And so that really just means that we can't rely on vaccines alone. In the near term, at least, this means that we have to rely on other measures as well alongside vaccination. And the thing that, is really important to remember is that, in Ontario, we've had really high vaccine uptake. We're almost at 70% now of the entire population fully vaccinated. But that means that there's still over 4 million Ontarians who are unvaccinated. And because the Delta variant is so transmissible, the number of people who are still susceptible are such that we can have a really sort of overwhelming wave of transmission happen if we don't have these other measures in place. And as I said before, that will place a huge stress on our healthcare system, as well as the other effects that Arjumand was talking about that we don't talk about enough in terms of long COVID and other consequences of infection. So what the science table is recommending is that, in addition to focusing on vaccinations, we really need to think about other ways that we can reduce opportunities for transmission to happen, particularly in indoor settings, because we know that indoors is really where transmission happens the easiest. And so the ways that we do that are, first of all, reducing the amount of time that we spend indoors, which is obviously harder as the weather gets colder, maintaining physical distancing, focusing on things like ventilation and air filtration, wearing high quality, good fitting masks and respirators. And then the things that we've been talking about since the beginning, testing and contact tracing, providing supports for those who need to isolate. And I think the one thing that's been underused and is at least starting to be on the radar a bit more is the use of rapid tests. But again, it's not one single thing. It's really this combination of interventions that we need to have in place until we have enough immunity in our population that we can start relaxing or dialing back some of these other measures.
Thanks. You have such a clear way of explaining a complex suite of approaches. Thank you for that. So Arjumand, back to you and back to my sharing screen to show the question. I guess, I start being a little bit more politically engaged with this question, though I think it's still well within the scientific realm. Despite the advice from the Ontario Science Table, university presidents persuaded the Ford government to give universities an exemption from Step 3 restrictions. So that means that some universities in Toronto and elsewhere in Ontario set about increasing indoor density, abandoning physical distancing, increasing the number of large gatherings, and radically increasing rather than decreasing the number of contacts. For you and Ashleigh both, I guess, do any epidemiologists that you know endorse this approach? The Dalla Lana School of Public Health, at which you both teach, is staying fully online, at least for the fall. And our local public health units, Toronto and Peel Public Health, also continue to strongly recommend at least 2-meter physical distancing and reduced density indoors. I think we've heard a lot about the precautionary principle during this pandemic. In this context, what does the precautionary principle suggest universities ought to be doing now? And Arjumand, I'll ask you maybe to speak to this first.
So, to start with the first part of your question, I don't know any scientists who endorse the approach of relaxing these kinds of guidelines, particularly on mass scenarios. Classroom teaching is very sort of long process. We're in classrooms for hours, and I haven't heard anyone say that this seems like a reasonable approach. I think there is a lot of concern about the fact that if we were to do this, the motivations are decoupled from the goal of maintaining at least some control of the pandemic. There is severe concern, and I'll let Ashleigh speak to this because she's the infectious disease specialist here. There's severe concern that doing this will expand wave 4 in ways that we really can't imagine right now. I think we've been lulled into a sense that it's okay to relax these measures. It's okay to ask Ford to allow us to gather because we're all vaccinated and that should do the trick. But if you ask scientists, I don't think they're on board with that logic in any way, shape, or form. And I'll hand it over to Ashleigh.
Thanks.
Yeah, I mean, like, I agree with Arjumand. It's scientifically, it doesn't make a lot of sense. We're talking about the need to reduce contacts. And so putting large numbers of people indoors in small, crowded spaces, or not necessarily small, potentially very large classrooms, it's counter to sort of what we need to be doing right now. And I think, early on in the pandemic, there was this concept of like a social interaction budget. And I think it's such a useful concept, which is basically, we can have a number of interactions as a society, and we have to choose how we want to spend those. And, if you sort of exceed that budget, we're going to spur transmission, and it's, we're going to have to start talking about, implementing policies to get transmission back under control. And I think throughout the pandemic in Ontario, there really has been a huge cost to children. We decided that, we were okay with shutting down schools, because that was easier to do, for example, than, doing other potential policy measures that we might have done. And I think, at this point, who are the most vulnerable? It's kids. They're in schools right now. The number of contacts that they're having has increased dramatically. And so, we have to cut down contacts somewhere else in our society. And I think, one of the obvious places is, thinking about work and, can we continue to work remotely? Again, thinking, less about, individual risk and more about societally, what are we willing to do to protect those who are vulnerable? And so, this is a bit of a shift away from, I think, the focus of the evening, but I think it's an important thing to think about, which is, kids have been out of school for a long period of time. And the way that we're headed right now is, I think a lot of places are heading back to work. They're going to be spending a lot of time indoors in colder weather. And, at some point, something has to give. And the question is, what is it going to be?
And it's interesting. You made me think about us having our carbon footprint and then also our contact footprint. And we need to be mindful of both as we head into it. And we're about to transition to talk about both social and personal ethics. But I think part of what the faculty associations and the unions who are part of this coalition have been thinking about is, how can we get reopening right so that we don't cause community spread? And how can we get that reopening right so that we don't have to disappoint all the students who are going to be forced back into some kind of online learning because we were perhaps overly ambitious or we took risks we didn't need to take? I'm not sure if that's the way you folks think about it, but we think about it in terms of how not to put people who work or learn on campus in harm's way, first of all, and second of all, how not to harm the community, and third of all, how to get it right this time, because a year ago, I think we tried to do too much and we got it all wrong. Let's head into our second round, where we're going to put a focus on bioethics. And I think a lot of the chatter I've seen so far has really focused on the question of what we owe each other and what our individual or social rights might be. So I'm just going to very quickly share the screen and invite Ross Upshur, our resident bioethicist, to answer 3 questions that may further animate people in the chat or otherwise. And they are, what ethical obligations should universities be weighing and addressing at this moment in the pandemic, perhaps with David's comments in the background? What are the most important questions senior administrators should be answering now? And what about the ethical obligations of the rest of us? What do we owe each other, this institution, our students, or anybody else? And I'll stop sharing and invite Ross to answer.
Thank you, Terezia. I'm grateful for the opportunity to be with you here tonight, and I hope everyone is as well and sane as they can be under the circumstances. It's been a very trying 18 to 20 months. So I'm going to reflect a little bit on over 20 years of working on epidemics and ethics. We're fortunate in Canada that we have the problem of an abundance of vaccines to argue about whether we should have a mandate or not, recognizing that a large proportion of the world has no access. Secondly, to recognize that pandemics are actually about human issues. Yes, science can tell us things, but it actually doesn't tell us what to do. It's only when we engage with the goals and the values and the norms that the science actually makes sense when we put an interpretation around it. I want to start by addressing the first 2 questions about what university administrators or authorities, what responsibilities they may have. And I want to situate this with a little bit of a long view by bringing back the Campbell Commission report from the first SARS outbreak in 2003. For those of you who haven't read it, it's about 1,200 pages, and good luck finding a PDF copy because they've all been archived. But Justice Campbell was a very thoughtful man, and he was hoping that his report would not sit on the shelf as many other commissions of inquiry have. I often think we should have a course on all of the Royal Commissions and Commissions of Inquiry in Canada to resolve difficult issues that we face, to look at the recommendations and whether we've acted on them. But he was very clear and unequivocal about one thing, and it is a bit of a controversial topic. And of course, as academics, we can debate the merits and the criticisms about what is called the precautionary principle. Now, it's also instructive to remember that when Justice Campbell invoked the precautionary principle, he cited Justice Creever and the so-called tainted blood inquiry. And so the commonality for both of these is the notion that greater scientific certainty would somehow give greater direction to decision-making. And I'll quote from the Campbell Commission, and then I want to speak a little bit more generally about infectious disease ethics and pandemic ethics. He says, the Commission therefore recommends that the precautionary principle, which states, and there are about 8 different variations of the precautionary principle, that action to reduce risk need not await scientific certainty, that this be expressly adopted as a guiding principle throughout Ontario's health, public health, and worker safety systems by way of policy statement, by explicit reference in all relevant operational standards and directions, and by way of inclusion through preamble, statement of principle, or
Ross, I'm going to do our interpreter in favor and remind you just to slow down your speech a little bit. It's awfully difficult to do. When you're reading something, they were reminding us that we have a tendency to speed up. I'm loving what you're saying, but I just ask you to maybe slow it down a wee titch.
So, but the important thing is by way of inclusion through preamble, statement of principle, or otherwise in the Occupational Health and Safety Act, the Health Protection Promotion Act, and all relevant health statutes and regulations. Furthermore, he states that in any future infectious disease crisis, the precautionary principle guide the development, implementation, and monitoring of procedures, guidelines, processes, and systems of the early detection and treatment of possible cases. So the university, which authorities, administration, which has the responsibility for the health and safety of staff, faculty, and students, must be convinced that they are meeting this standard. And I think we'll have a discussion about the checklist. And I think the checklist is a thoughtful document that lays out what needs to be done to meet those occupational health and safety standards, but I'll let my colleagues speak to that. So those are the questions that they need to be assured of, and they need to be able to be trustworthy in providing those answers. They need to be transparent in the arguments, and the arguments need to be well justified. But I do want to speak more generally about what pandemic ethics entail, because there's a large literature on this, and it's a thoughtful literature. There's this notion that pandemics engage all of us in some form of relational community. The fact that infectious diseases underscore the fact that we can be both victims and vectors. That is, and that's happened in less extreme examples than the pandemic. All of us who are alive have received an infection from somebody we love, and we've probably transmitted it to someone we love. So this notion that we are somehow isolated atomic individuals is actually very much defeated by a pandemic. And there's accounts, for example, by Susan Jerwin, Françoise Baylis, and Noella Kenny on relational autonomy and the relational perspective and relational solidarity. I think it's really important that we try as much, despite I see all of the difference of opinion in the chat line, that we try to find common ground and our common humanity in this, because we are not well served by divisive debates, particularly, as I say, when each of us can be a victim and each of us can be a vector. In general, there's a broad moral obligation, strong prima facie obligation, not to cause harm to others by transmitting infections. But as Harris and Holm have argued, and a very strong and important principle here, and again, something that the university authorities need to take seriously, is this notion of reciprocity. So the reasonableness of living up to the obligation depends on society reciprocating the obligation in the form of providing protection, support, and compensation to those who become ill. So we do have an obligation to not spread infections to others if we can otherwise prevent it, but we need to arrange situations and systems that makes this possible for us to discharge these obligations. I'm really happy to talk about vaccine mandates if anybody wants to. We've, I think, produced a very thoughtful document at the WHO on what the ethics of vaccine mandates are. Part of this being clear and clarity about the language of what mandatory actually means. But I was to keep my comments to 4 minutes, so I will stop now. And I'll apologize to the interpreter for getting into my fast talking mode. Thank you for the opportunity to be with you tonight, and I look forward to the discussion.
Thanks. And we'll be sure to have some follow-up questions on the vaccine mandate in the second round. Thanks very much. I'm just going to invite the panelists, whether you're speaking or not, to feel free to keep your cameras on. In particular, when the panelists are interacting with each other, I would hope that they would keep their cameras on so we can get a little bit of a sense of our being a panel rather than a series of individual speakers, particularly as we head to the third round. And I'm going to share my screen once again to set us up for this third round. So if part 2 had a focus on ethics, not that we're abandoning our ethics or anything, part 3 is focusing on mitigation strategies or the checklist. And I guess the first question that we have for James is, why did you and Jeffery Siegel and others create a health and safety checklist for university reopening, and what purposes does the checklist serve? Over to you, James.
Okay, thanks very much, Terezia. Hopefully this is working. So I want to hear Ross talk more, because I really enjoyed what Ross had to say, and hopefully we can pull some of that back into the conversation, because I think it's extremely valuable. So myself, along with colleagues that Terezia mentioned, have been involved in the Central Health and Safety Committee through UTFA for at least the last year, perhaps year and a bit. And as a consequence of that, we've had a number of many discussions with the central administration around health and safety issues specifically related to COVID. And it's clear to all of us that the university has put a lot of effort into trying to assemble bits and pieces of a COVID strategy. One of the issues, and it's been a great challenge for us, and it probably is for my academic colleagues as well, and others that are on this call, is that many of these bits and pieces that the university has put together are in a range of different places. There are different versions. It really has not been completely clear where any of that sat. So So along with my colleagues, we went through a number of these documents and tried to pull them together to understand sort of what the central strategies were and where the gaps were. And as we started looking at these bits and pieces, we found a number of things that we identified as clear gaps where we actually, these are things that we know need to be done that weren't there. And then other things that we think are important that weren't there. So we felt that the best way forward to deal with this was simply to put together a checklist that summarized the things that we really think are important, and along with the things that we know are important. And then that can be brought to bear just as a tool for faculty, for the unions, for anyone on campus, as well as at other universities, if it can be made available more broadly to start to inspect those strategies that folks have and make sure that they address the things that are really important.
Thanks for that introduction to the checklist. I won't share my screen for the next question for Jeffrey. Of course, this checklist has been taken up by groups across the province. Jeffrey, can you help us better understand the main items on the checklist and why it didn't stop at vaccines? Why do we need a checklist, and why are vaccine mandates, or are vaccine mandates enough to keep us safe? Or I guess implicitly, explain why we need a checklist rather than just vaccine mandates.
Sure. So, right back very early on, long before I was born, in the discussion of infectious disease, there is this idea of a layered approach to preventing transmission. And that layered approach means that, no layer is perfect. Vaccines are wonderful, but they are not perfect for reasons we've already heard. And in fact, in no one layer we can do. Masks, filtration and ventilation, nothing is perfect. So the idea is you want to get as many layers as possible, and you want to do each layer as well as you can to minimize the risk of transmission. And so the fundamental idea of the checklist is to take that idea and codify it as a set of approaches, principles, ideas, things that need to be done. And the checklist has important information, kind of overarching information around transparency and communication, around the overall goals that are really important. And then in the details of the checklist, there is specific evidence-based actionable information on things like ventilation and filtration, and the details of how to do those things and how to verify that they're working, as well as things like Legionella, which hasn't come up yet and hopefully will come up more in the discussion, which is something that arises in water systems when they're not used and can cause problems all of its own, around masks and around other layers of protection that we need to be thinking about in our buildings. And one final point I'd make on the checklist is the checklist will only serve to make for a healthier, safer environment independent of COVID-19. So what I mean by that is the checklist should be followed because we will have a safer and a healthier environment with better learning outcomes, better health outcomes, a variety of other aspects.
And I'm wondering, I see in the chat, I've been able to catch out of the corner of my eye the notion of the layered approach or the Swiss cheese model. I think it's such a vivid and helpful analogy. I'm wondering if you could help people who don't understand what people are chattering about in terms of the layers of protection or Swiss cheese model, better understand that and how it maybe connects to the idea of a checklist.
Yeah, absolutely. So the idea of the Swiss cheese model, like you said, it's very brilliant. Whoever came up with it is very brilliant. But we have all these layers of protection that we should be using. But because each layer isn't perfect, there are holes in the layer. There's kind of a layer porosity, if you will. And if holes line up with each other, there is, you can think of it as a pathway between an infected individual and a not yet infected individual for the virus to pass and infection to occur. And so the whole idea of the layered approach is, first of all, many layers will diminish the chance that the holes line up. Doing each layer well will diminish the number of holes. And then there's also this issue we have to think about, I think, in the context of U of T and the checklist specifically, is that, there's this whole idea of layer bypass. We can, for example, just pay a lot of attention to classrooms, and there are, of course, many other spaces where transmission can occur. So the whole idea of the layered approach is, thinking about the layers and their quality and the number of them, but also understanding that you have to think about the whole possible chain of infection.
Thanks so much. And UTFA is going to try to put a visual of the Swiss cheese approach up on our website. I know that you had it in one of your departmental presentations. I've been talking about Swiss cheese for a year, and I don't think talking about it is half as good as putting a visual up. It's quite a striking image, but I think you did the best job possible painting a picture for us. So thanks for that. So the next question I'm going to ask you and Paul both to address. Are full capacity university classrooms with hundreds of students in them and no physical distancing compatible with the public health standards laid out in the checklist? Put another way, are they a good idea and supported by the scientific evidence that the checklist suggests?
Okay, so maybe I'll jump in first and then put it over to Paul. So the thing I would say about classrooms is, this is the magic force field approach to pandemic protection. Like, because teaching in a classroom is really important, that, disease transmission doesn't occur. We heard earlier, you can't negotiate, you can't bargain with this virus. There's something, the virus doesn't care that it's a crowded classroom or a crowded another environment. The virus doesn't care how important the activity is that's occurring in the space. So all I can say is, there is no sound justification for getting rid of the layer of physical distancing. And I'll turn it over to Paul.
Sure. I mean, yeah, the idea that physical distancing is all of a sudden eliminated just goes contrary to what we've learned from the pandemic thus far, and also what we've learned historically from studies that have looked at other infectious diseases that are airborne. The closer you get together, the easier it is for one person to transmit it to another, and the less chance that the ventilation system and the masking and if you have a vaccine that may reduce your viral load potentially, all those things just come together in a big swirl, and you're not allowing the systems to work as well as they should. So it's not eliminating the risk if you all of a sudden go to 2 meters. There's nothing special about 2 meters. It's just a number that we've been found historically tends to lend itself to a low risk. So just like ventilation in general, distancing will reduce your risk. You combine that with good ventilation, you combine that with good source control like masking, you combine that with vaccines, which hopefully are slowing down or at least trying to prevent the spread, then you're just increasing the level of protection you provide if you do all of those things, including physical distancing. By chopping off one of those layers, you're again just increasing your risk. Quantitatively, I would wish somebody could tell me how much it would increase it. But unfortunately, with the Delta variant, it's too new. We just don't know. So again, we should be invoking the precautionary principle and saying, in the absence of firm data, they did lots of modeling last year with the original variants and talked about how good ventilation needs to be to try and control indoor spread. But without the physical distancing, we just don't know if it's going to be good enough this year with the Delta variant.
Thank you both for that. That's very helpful. And I'm going to transition to a slightly different angle. You spoke, Paul, about what we don't know. There is a lot of information that is available that isn't being shared. And I want to highlight one particular part of the checklist. The checklist asks university administrators to proactively and transparently share information with JHSCs, Joint Health and Safety Committees, campus unions, faculty association, employee representatives, so that the sufficiency and efficacy of the safety precautions that are in place can be assessed. So that's in the checklist. And I know you teach about occupational health and safety. Why is transparent health and safety information sharing with JHSCs and the people who work and learn on campus important in general? And specifically, why is it so important right now?
Well, if you're talking specifically about information like the ventilation systems, for example, and the amount of air changes per hour, or how many portable units have been installed, or things that can help us decide, or at least attempt to make some risk assessments for ourselves, even if we're not experts in doing risk assessments, to try and assess, is this a riskier situation that I would like to avoid, or I think I might need to take additional precautions. It's nice to know that information, but it's also a legal requirement. Of course, anything that the administration has in terms of test results or measurements can be considered health and safety information. And of course, under the Health and Safety Act, those of us who are paid to be in universities have our 3 basic rights under the Act: the right to refuse unsafe work, the right to know, and the right to participate. And of course, if they've got consultants or ventilation companies coming in, for example, and measuring the amount of airflow through our classrooms and the rest of our buildings, that information is presumably therefore being collected because they're trying to assess our risk to getting a disease. And any report respecting health and safety in the possession of an employer is required under the Health and Safety Act to be shared with both the joint health and safety committees of that organization, as well as any individual worker who asks for a copy. That's one of the expressions of what the right to know really means. So, it's not like, we're asking for the summary data, because the summary data may be good for some of us, but it might not give us a complete picture. It's not like we're trying to ask for something that, we're trying to play a game of gotcha or audit the math and the calculations performed if they're showing us ventilation stuff. As a former health and safety consultant, again, who teaches graduate students how to do this kind of stuff, I know that, a competent technical report will provide context to the measurements. They will talk about the equipment used, the strategies for testing. They might even talk about the limitations, hopefully, and more importantly, as the person directly measuring the system, they might even provide recommendations for further testing or actions. And we don't want those to go directly to the employer and not be shared with the health and safety committees, and again, those who have a right to this information under the existing health and safety laws. So to me, it makes sense that the raw data, the raw reports for anything that is being measured falls within the requirements of the Health and Safety Act as information respecting health and safety, and therefore must be shared, again, both with our joint health and safety committees and any affected employees upon request. It's not confidential information. It's simply the information that we can also use to ensure that we have confidence in things like the amount of airflow or filtration that are protecting us from risk of infection.
And I'll say, because you folks have so far been too modest to say, at the University of Toronto, where you serve on the Central Health and Safety Committee, the abundant expertise of the public health experts is not being put to appropriate use. And if you follow social media, there are an enormous number of comments from university professors who can't believe that in institutions that celebrate evidence-based decision-making, key data is being withheld from the very people who are probably in the best position to interpret it. It is one of the greatest frustrations of my time in leadership at UTFA that I have what I think is an extraordinary group of public health scientists and an extraordinarily untransparent university administration that won't appropriately use all the expertise that's available right within its own ranks. But I'll stop talking about U of T now and move on to the next question. I know this is happening at other universities, as knowing about ventilation. And the next question is precisely about that. I'll share the screen and then read the question. Why has ventilation turned out to be such an important issue and source of conflict across Ontario universities and beyond? Why is this now something people are talking about province-wide? What's at stake in the conflict? And just how important is it to have good ventilation? Really, is it that important?
Yeah, so you can probably predict the answer. I'm going to answer that last question first. It is enormously important to have good ventilation, and this has been well recognized since as long as we have had buildings. And so I think it's, there are very clear and cogent writings from hundreds of years ago about how important ventilation is and how important ventilation is to reducing the transmission risk for infectious disease. I would also comment that, hearkening to something I said earlier, that ventilation is enormously important for our well-being and our health in buildings. And so, the list is so long, and nothing I'm about to say is anything but completely settled science. But when ventilation is poor, we see reduced productivity, reduced cognitive function, higher absenteeism from school and work, reduced learning outcomes, a very long list, not to mention serious health concerns that arise from poor ventilation and exposures that result from poor ventilation. So ventilation is clearly very important. It is also contentious, particularly in the context of infectious diseases. Some of that harkens back to the debate about how airborne the disease was that unfortunately occupied a lot of bandwidth early on in the pandemic. And so there was not attention paid to ventilation, as well as the fact that, let's be perfectly honest, how often do we care about ventilation before the pandemic? In my entire career, I was happy if I could get, a few people excited about the kinds of things I do with ventilation, filtration, and indoor air quality. And, now, it's every week. I talk to lots of people and people are engaged in the problem. And I guess the one comment I'll make is that I sure hope that continues beyond the pandemic, because the importance is obviously important for COVID-19, but it's important for many other things beyond that, and will be important in the future.
I'm sure I'm not the only one who's saying to people, what's the downside of over-investing in ventilation? You might actually have alert students and a nice place to work. I'm mindful of time. I know that for a bunch of us, we could ask you questions about ventilation for another 15 minutes, but I want to head to the history. I'm just wondering where the question is on history. I was supposed to do that first. Okay, never mind. Here, we have it now. So back to the humanities, and this time, James. What does longer term and shorter term history teach us about the handling of this pandemic, including with respect to the debate about the airborne transmission, which we've already heard about, of COVID and other diseases? Can you situate all of what we're talking about in a quick 3-minute summary of the world history of infectious disease?
No,
if anyone can do it, you can, James.
I'll try. So we first learned about the ability of biological particles to move around in the air in the 1830s, and we found it out because of Charles Darwin, who swept some dust off of a boat, the Beagle, and it turned out to be algae that got in the air through droplet nucleus formation, which is the same mechanism that SARS coronavirus 2 uses. Fast forward from about 1835 to the 1880s, when lots of areas in Europe were in the midst of cholera epidemics. And because of that knowledge of how things moved around, in part thanks to Louis Pasteur, folks started sampling the air with measured volumes of air to look at biological particles in the air in the search of the transmission route of cholera, which of course turned out to be waterborne. But it started a science called aerobiology. Now, of course, cholera was largely solved not by vaccinations, but by building sewer infrastructure. And then if we fast forward from there into the mid 20th century, William Wells taught us how the transmission of tuberculosis functioned. And the building that I'm sitting in right now, from 1915 until the late 1960s, early 1970s, served as the headquarters of the National Sanitarium Association, which was the organization that operated tuberculosis sanitaria across Canada. And tuberculosis was largely managed at that point, absent vaccines or drugs, with improvements to ventilation. So if we move then from there and fast forward to 2003 with the outbreak of SARS coronavirus 1 and the report that my colleague Ross Upshur alluded to that was released in 2007, 14 years ago, Justice Campbell highlighted that SARS coronavirus 1 was airborne and mandated the need for a precautionary approach to dealing with outbreaks of a similar sort. So that was 14 years ago, and you don't need to be a virologist to guess that SARS coronavirus 2 might be a close cousin of SARS coronavirus 1. So we already had basically a manual that gave us some very good guidance on how to deal with this outbreak 14 years before the outbreak happened, and it stayed on the shelf. So that's sort of the sad history of this. It'll give me something to talk about in lectures, but it's as you can see, really problematic.
Well, I learned about the precautionary principle from David Fisman, who I'm very glad to hear has joined us when we first tried to mediate a solution to what was a mishandled initial approach to this pandemic. And I wish everybody who was a decision maker on all 4 of these campuses and all the campuses actually were forced to participate in some meaningful education on what constitutes adherence to the precautionary principle. But alas, this ends the first round of our panelists' responses to the questions that were sent in ahead of time. We are going to very briefly hear from representatives from each of the 4 universities. They're pre-recorded and we're going to run the tapes. And then in the last half hour, we're going to gather the questions from the Q&A. And we already have an excellent one that has to do with shared bathrooms and all that goes on in bathrooms. So stay tuned for that. But I'm going to turn it over to the tech people so that we can hear from Lori Jacqueline, Nicole Collins, Amy Conwell, and Jody Burland from X-University, OCAD U, U of T, and York.
Lori Jacqueline, President of CUPE 3904, representing contract faculty and teaching assistants at X-University. I'm here on behalf of Ian Sakanowski, President of the Faculty Association, and our colleagues Kelly Lochaville at OPSU 596 and Jennifer Barang leading the CUPE 233 Physical Plant and Trade Units. This solidarity is replicated in our larger Toronto 4 University Coalition. Indeed, COVID has proved to be a unifying force in our unprecedented solidarity. The X-University administration designated this fall semester as a transition term. Due to our collective advocacy, the university is now offering less than 15% of the usual number of in-person instructional sessions on campus, which helps mitigate the risks to all faculty, staff, and students on the campus. By and large, the only people teaching in person are those who made a conscious decision to be there. That said, our administration indicates that they intend to remove all restrictions and capacity limits in instructional spaces for the winter term. At this point, this decision is not supported by any science. One of the most startling realizations during ongoing discussions is the extent to which our employer focuses on restarting the organizational machinery rather than concentrating on the safest environment possible for every person, We constantly encounter a bureaucracy that considers COVID as an operational inconvenience rather than a large-scale public health and safety hazard. For instance, and in response to the Inter-University Coalition's health and safety checklist for university reopening, X-University responded to our urging to monitor ventilation and air quality in all campus buildings. They assessed the quality of air in hundreds of classrooms. Our coalition received a list of summary findings rather than the specific quantifiable data as requested by expert scientists on today's distinguished panel and in the checklist. Unfortunately, the university limited the ventilation assessments to the classrooms that it considered to be high risk and did not test any of the 3,500 offices and common spaces. We continue to wrestle with this decision, as well as the recently announced policy requiring mandatory proof of vaccination, but in the latter case, only due to the lack of clarity around the implementation. Thank you for the opportunity to provide this update, and we look forward to continued solidarity.
Nicole Collins. I'm Associate Professor in the Drawing and Painting program at Ontario College of Art and Design University, and I'm also the OCAD faculty representative on the Joint Health and Safety Committee. OCAD University is centered in a studio-based pedagogy, and the loss of in-person contact for all courses has had a significant impact on students, faculty, and staff. OCADFA has used many channels with administration to ensure the checklist was prioritized. We shared it with our membership at large. Our union reps on the Joint Health and Safety Committee tabled the checklist as an agenda item to be discussed and recommended, and we also presented it to the Ad Hoc Gradual Reopening Committee that is comprised of management and campus union reps. Administration issued a timely public response to our checklist in mid-August, and we will be monitoring the implementation of their promises through the coming months. This fall, OCAD's classes are mostly online. 30% of studio classes have some face-to-face on-campus component. Specific rooms and spaces have been designated for face-to-face classroom studio work. Faculty have the latitude to work out details of how in-person classes will be delivered. For example, sections may be divided into smaller cohorts, and in-person meetings can take place with these groups in their assigned rooms on campus. Despite the recent announcement by the Ministry of Colleges and Universities removing the need for physical distancing and/or capacity limits in instructional spaces this fall, OCAD University will take a more cautious approach and has chosen to maintain the requirements for physical distancing in all spaces. Masking will be required indoors, allowing for medical exemptions. There is a vaccine mandate on campus with exemptions on medical grounds, and proof of vaccination is required. Those who are unvaccinated must take twice-weekly tests and provide a negative test result to be permitted onto campus. All these protocols are being managed with the OCAD U Safe app. Vaccine education and access to clinics are available. OCADFA has taken the position that regardless of vaccination status, everyone has a right to an education and no one should be denied employment. We expect administration's vaccine policy to be equitable, compassionate, and inclusive. We know there are international students whose vaccines may not be recognized in Canada. If our members do not want to be vaccinated for medical or other reasons, we will advocate for them to be provided appropriate accommodations so they can work remotely. If members are vaccinated but do not feel safe working in person on campus, we will also advocate for them to be able to carry out their job remotely within reason. OCADFA recognizes the necessity of vaccine mandates right now, but have taken the position that these mandates must be implemented with compassion. There are many issues: privacy, employer overreach into personal freedoms, and the securitization of campus that we are concerned about and will monitor. And we know vaccines alone are not the answer. As a union with a social justice mandate, we believe broader societal change is the most critical response that can meaningfully address this virus.
Hi, everyone. I'm Amy Conwell, chair of CUPE 3902, the labor union representing contract academic workers at U of T. I'm providing a U of T report on behalf of CUPE 3902 and our campus partners, the U of T Faculty Association and USW 1998. This September at U of T is chaos. There is no central plan for course delivery, remote work accommodations, and health and safety for in-person work. Plans are developed at the unit level and thus vary, Some units, such as the School of Public Health, have elected to go online. Others are fully in person. Others leave course delivery to individual instructors' discretion. Students, staff, contract academic workers, faculty, and librarians want to get back to in-person work, but they need to know that it is safe enough to do so. As it is, plans are unclear, changing, and last minute, and the university is choosing to overwhelm workers with many dense emails rather than provide clear communication. As a result, precarious workers are making the hard choice to turn down contracts or resign rather than put themselves and their families at risk. We have made repeated requests for unions, the Faculty Association, and student groups to meet collectively and work collaboratively to discuss these issues. COVID impacts all of our immune systems, and its prevention concerns the entire campus community. But U of T will only meet with us separately at short meetings where they are unresponsive to our concerns. They continue to dismiss our asks, including the latest health and safety measures we've called for as part of the checklist for a safe return to campus, developed by leading public health and safety researchers at the U of T's own School of Public Health. Notably, they refuse to make any changes or provide any information that would hold them accountable, such as information about the current ventilation statuses of the buildings in which we work. We continue to be concerned with the university's lack of plans for the fall. While they have a mask-wearing mandate, they have no plan to enforce it. Can workers refuse to interact with unmasked students or members of the public? Would they face discipline for doing so? We don't have the answers to these questions. Likewise, there are many questions related to the enforcement of the vaccine policy. In addition to our concerns about enforcement, we are also dismayed that U of T has denied workers access to requested reasonable accommodations in cases where in-person work would put them and their loved ones at risk. It is shocking that instead of creating careful plans to bring workers and students back to in-person work safely, U of T lobbied the Ford government for exemptions to Ontario's Stage 3 safety measures. Just this morning at U of T's Governing Council, President Gertler and the Council embraced the opening up of campus and lifting of regulations, sidelining the significant concerns raised on behalf of our community. As a first step to resolving these many issues, we call on President Gertler and the Governing Council to refuse to enact the Stage 3 exemption. Post-secondary institutions are close quarters, congregate settings, petri dishes for the Delta variant and other variants to come. We need capacity limits and distancing measures in place to prevent the spread of the virus and keep our campus safe.
Hi, I'm Jody Berland. I'm a member of the York University Faculty Association Executive, and I'm really pleased to be speaking today on behalf of UFA and CUPE 3903 at York University. York does now require students, staff, and faculty to post online proof of vaccination in order to access campus. They have also issued a voluntary daily screening software. UFA and CUPE 3903 have endorsed a joint letter calling for better documentation of the health and safety measures. It has been signed by hundreds of faculty, staff, and students. The employer has assured us that social distancing will be restored, but we have a lot of questions still, and we will continue to work together to ensure better health and safety protections at York. The university's website states that we are at level 2, which means moderate degree of caution, and they're calling for 30 to 60% of classes to be taught in person. So we have a number of unresolved questions. First, are there room capacity limits? It's not clear. A lot of classes still don't have rooms assigned. We heard of one class where there were 27 persons assigned to a classroom for 32. We don't know what's happened to the room capacity restrictions. Secondly, there was a formal protocol for contact tracing for students and residents. We don't know how that will be enforced across the university campuses. Thirdly, we learned last week that the employer has contracted family status accommodation requests to a private contractor, OSI, and almost none of them have been approved. Some chairs today were told that there's now a review process if your family status request is rejected, but we have not been informed of the review process. We don't know who will review the decisions or on what basis. Fourthly, how is masking to be enforced? Is it up to faculty? Does a masked student or instructor have to leave a room because they don't want to be near unmasked persons? We have no clear directions on this regulation. And Finally, looking at the stats on online versus in-person classes, it's clear the employer made a massive miscalculation about students wanting in-person classes because they asked if they preferred online or in-person, not whether they preferred online or in-person during a pandemic. So given all this, we want these three assurances. First, we need evidence to support the assurances being provided in response to our coalition's checklist. We need to know that social distancing and room capacity restrictions, masking, physical distancing, ventilation, and sanitation measures are in place with an adequate investment in maintenance. Secondly, we need assurances that faculties whose courses are canceled are not negatively impacted. And thirdly, we need a much better equity-oriented accommodation process so that people who have family caregiving responsibilities do not have to expend unnecessary energy appealing the almost 100% negative decisions of a private corporation contracted to process our family status accommodation requests. So thanks for listening, and thanks to my coalition colleagues for putting this together.
Thanks very much to those presenters. Now we can head to some of the questions that we've been receiving throughout today's presentation. And as promised, I'm going to begin with a question related to bathrooms. And I'm going to ask the panelists to weigh in and organize themselves. And then following this, I have a question on public transit, and then I'll give you a sense of where some of the other questions are going after that. The question reads thus: much talk has occurred about air quality in offices and classrooms, but I've not heard or seen any about the shared bathrooms that students and faculty and staff use. These have no lids on the toilets, so aerosols are airborne when flushing. Given SARS-CoV-2 is found in human stool, this is a concern. Has the issue of bathrooms been on the radar of faculty associations or university administrators, or you folks are public health experts? James.
Perfect. I was supposed to be teaching public health sanitation this fall, so this is going to give me a little bit of practice at that. So SARS coronavirus 1, just like SARS coronavirus 2, was also shed in feces, and we know at least one very well studied outbreak in the Amoy Gardens Hotel in Hong Kong related to feces, though going through the air in plumbing systems. So similarly, here we monitor SARS-CoV-2 in feces as an indicator of population burden of disease. So for sure, it gets deposited in toilets when we deposit solids in the toilet. Now, the ventilation systems in washrooms normally will exhaust through the ceiling because humans produce, for the most part, lighter than air odors. So it sort of makes sense to be able to draw those up. The problem is that when you flush the toilet and release droplet nuclei into the air, gravity, as soon as the water evaporates, draw those down. So the capture velocity on that exhaust, if it's even functional in the washroom space, is not necessarily going to effectively capture those. And those will settle over time to the floor. They may be resuspended as people go and walk through and move around. So absolutely, this is a concern. This is a huge concern. And we've known that this is a concern since the beginning of this outbreak, but it's been very difficult, at least for us through UTFA, to engage our university. And I suspect others have the same problem.
I'm wondering if anyone else wants to weigh in. Maybe Jeffrey, this is an opportunity for you to comment on the decision, at least made at U of T, but probably elsewhere, not to improve ventilation in any place other than classrooms.
Yeah, so I want to start that by echoing a lot of what James said, and everyone after this who's interested should Google Amoy Gardens Building E in Hong Kong. And it's a fascinating story, and I could talk about it for the rest of this meeting, but won't. But so bathrooms represent multiple risk pathways for transmission of infectious disease. You heard about the plumbing venting can be a transfer pathway for the disease. You heard about, there's something called the fecal oral route, which is as disgusting as it sounds and is another potential route for the disease. And then don't forget, bathrooms are small spaces, often where people are relatively close together. They have very smooth surfaces, which is going to lead to potentially more resuspension. And we also have this scenario in a university where, you know, at changing class times and so on, bathrooms are even more crowded, not to mention that we have some bathrooms out of service because of Legionella concerns. So what this means is that bathrooms are a potential area of risk and certainly need to be addressed along with other common spaces in buildings.
Oh, I have about 6 things I want to ask about. Okay, I'm going to ask one because it seems to be rather crucial. Not only at U of T, but at other places, when faculty associations or staff unions have asked for shared data on ventilation in bathrooms or anywhere else, the data that was shared with you, because you were kindly offering to look at the documentation, constituted calculations versus measurements of ventilation. Could you describe, because there's a bit of a debate going on in the chat, why is it insufficient to calculate ventilation? Why do you have to measure it? What's the difference?
Very basically, the issue with calculation, and calculation is a great starting point, so I'm not knocking it as an idea. The problem is that the input data that you use and the assumptions inherent to your calculation will determine your output. And the specific issue with ventilation is if you go through all the input data to calculate the effective air exchange rate for classrooms, which is what U of T is providing, there is a ton of biases that all add up. And so what I have wanted to do from the beginning and still want to do is I would like to go and measure the effective air change rate in classrooms. And what we would learn from that, I believe, is that we would find that many spaces the calculations are optimistic. I would not be surprised to see they were optimistic by factors of, for example, 2 or 3. That would lead to very different outcomes than the calculation would suggest.
And just to be clear, because we've sat on these committees together, U of T has yet to take us up on our offer, extended more than a dozen times, to actually demonstrate to us that they've measured, you know, to have a representative sample of measurements. I think the next question is going to have to be on taking the subway to work. And I think we'll divide it up into 2 parts and maybe ask our modelers to help us understand the first part. And then I'm not sure who should help us with the second. The question is, I'd appreciate it if the speakers explain about the safety of using public transit, particularly TTC and the GO train in the fall term, especially if it's crowded. Due to my class schedule and family commitments, I'll have to use the subway during the rush hour. So the first question is, and I'm sort of dividing it up, how risky is it to use public transit in rush hour where there's no physical distancing? And then the second question, the second part of the question has to do with what, if anything, can I do to reduce the risk of getting COVID in the subway, or I guess spreading COVID in the subway? I'm not sure whether Ashleigh or David can specifically speak to what it's like to be on a crowded subway, train, or bus.
Well, I mean, there's some pretty evocative pictures that have been circulating on social media of what it looks like on TTC at rush hour. Look, Ashleigh and I teach infectious disease modeling at U of T, and we were talking this morning about the fundamental defining attribute of communicable diseases is old cases make new cases, right? For other diseases, sitting next to someone who has the disease doesn't make you have the disease. The disease is not a risk factor. Communicable diseases are different because proximity to infective individuals changes your risk. We quantify that as a reproduction number, the number of new cases generated by an old case. And you can break a reproduction number down really into 4 component parts. And the reproduction number is just going to be the product of those 4 components. One of those is contacts per unit time. Another of those is probability of transmission per contact. The third is how long are you infective for? And the fourth is what fraction of the population is susceptible to the infection. So you multiply those 4 things together, you've got your reproduction number. And if that's greater than 1, you have an epidemic. So putting that on the TTC, well, you know, the component of that equation that would probably be most heavily driven upwards by being on a crowded subway at rush hour is the contact rate, right? You're in shared air in a very, very crowded environment, very proximate to other individuals, some of whom probabilistically are likely to be shedding virus. And if you're doing that, you know, twice a day through the course of an autumn pandemic wave, is highly likely that you're going to come into contact with COVID. So what can you do to modify your risk? Well, you can wear a good fitted respirator, although that's, you know, that's not going to be perfect, particularly if you're repeatedly exposed. You can get vaccinated, which is highly, highly effective, not perfect, right? And that's, I mean, that's sort of what you got. So the idea in terms of, so this gets back to Swiss cheese, which I heard you talk about earlier. The idea is that you layer things on and use as many different approaches as you can to reduce risk of transmission. But of course, you know, the use of an overcrowded public transit system to go to and fro from campus, when frankly, I prefer teaching in person, but this fall we'll teach online, because that's just creating vulnerability where we don't need it for students or for faculty. I don't know if that answers your question, but
I think that's very helpful. It seems to me people are looking for individual solutions to what is a collective problem. I guess my first point would be, how can we set it up so that people are not on those crowded buses, adding to the crowding and adding to the risk? The other thing I've been taught by you fine folks is the first thing you do is not layer on protective equipment, you know, masks or shields or something. You try to remove yourself or remove the risk to begin with. Let's use this as a segue to masks. Would the person on the TTC or the person in a classroom that's overcrowded, is there any masking advice that you folks want to give people? Should we all be wearing, are the N95 grade masks needed at this point? James, I'll go to you first. And Ross, I also want to invite you to talk about whether you think our institutions have a difficulty dealing with collective problems of risk. Because it seems to me the TTC problem has the individual person trying to find a solution for a problem that is not individually of their making. If you don't like that question, answer your own. Okay. Anyway, James, go ahead.
Sure. So masks. So masks as personal protective equipment are a last resort. That's if you can't manage risk any other way, that's what you're left with. Then that's what you do. But it's very imperfect. So the best that an N95 mask can do really is effectively reduce your exposure by 2 log orders of magnitude. That's about all it can do. And if you're in an environment where there are 6 log orders of magnitude particles in the air, then that means that you'll still be exposed. So what we see is that healthcare workers who are using properly fit tested N95 masks, treating patients with them in their room for relatively brief periods of time, that there's still a substantial burden of disease in those workers, because those infectious particles still get through the mask, albeit in lower numbers. So what we've found is that the vastly more important use of masks is as source control. So that is, if everyone is wearing a mask that's got a couple of layers of fabric and it fits your face really well, then it captures those droplets before they dry to become droplet nuclei and then go on to float around and infect others. So masks as source control only work if everyone wears them. But if everyone wears them, then that greatly reduces the potential for airborne burden of viral particles that are potentially infectious. So that's really what we have to work with. I see a role for N95 masks and masks as personal protective equipment really only in narrow areas. Like healthcare is probably the best example, where you can't necessarily control the patient emission of infectious aerosol. So what can you do? You can properly fit test a mask and outfit that on the worker. But for members of the general public who can't fit test their mask to make sure that they fit, or who have facial hair or whatever, then that mask that on a healthcare worker properly used, that's offering 2 orders of magnitude protection, maybe is only lowering your exposure by 1 order of magnitude. So it's not really that helpful. Masks as source control, that's what we've got.
And I don't know if Paul has more to add to that. Just before I go back to Ross, one of the questions that we got offered had to do with, is there a place where people can get themselves properly fitted? The person had a longer piece about how desperate they're feeling and knowing that it seems all about the fit. Paul, if I understand correctly, you teach your students how to make sure people are appropriately fitted. If you're a member of the U of T community, a staff or faculty or a student, where might you go to get a properly fitted mask? Is this even practical? Does such a thing exist?
Well, the equipment to do it quantitatively, it exists in most of the hospitals and the university, and us academically, because we teach it, we have the equipment. I mean, it's also available to students. My own daughter, who's a nursing student, had to go to a private company to get a $20 qualitative test. It's not as good as the quantitative test that we would use for a worker who's in a high risk scenario. But there are companies that do fit testing. So if somebody really wanted to pay for it, yeah, it's possible. I mean, again, though, because we're not generally recommending these as personal protective equipment to protect yourself, it's something, if you can yourself look at the mask and see how tightly it fits on your face, make sure there's no gaps. Make sure that it's got the ability to tighten it around your nose. So those people who wear glasses and you put it on and you're getting a lot of fog because it's not tightly fitting around your nose, well, that means, again, it's leaking. So it's leaking on the way out, it's leaking on the way in. So you're getting it out when you exhale and get that fog on your glasses. So it's not perfect. But again, as James was alluding to, we don't have to have it perfect to reduce the risk significantly. And certainly he's got access to the data that I think I can remember correctly. I mean, even a loosely fitting mask will stop 20%. A well-fitted mask for exhaling can stop, upwards of 80, 90%. And frankly, because it's stopping the particles before they get out, before they shrink, that it's a lot better to do that. And the other thing you can do, again, if you're desperate, again, to worry about, and you're really keen on getting it as personal protective equipment to protect yourself, look for the ones that the KN95s are better than just a no-name mask. An N95, which are commercially available, are available on the market, but again, they're very expensive compared to what they used to be 2 or 3 years ago, when you could buy them at the any hardware store for $1 a piece kind of thing. It is possible to get better masks and to do some stuff yourself, if you want to take the initiative. And I just wanted to point out that, of course, the employer, if this was required, personal protective equipment would be required to fit test you. But of course, the Ministry of Labor at this point is listening to the Ministry of Health and saying, these are source control mechanisms. They are not personal protective equipment. So I have no hope that the employers sitting around this kind of table would feel any obligation to fit test you if you wanted to wear a mask. Let's put it that way.
Okay.
If I can add, and an N95 mask or a KN95 mask is really only going to perform close to that if it's really uncomfortable on your face. That's the reality of these things. They're difficult for healthcare workers to use just because they're extremely uncomfortable. So I think for the general population, it just isn't practical. I think the incremental added benefit just doesn't offset the lack of comfort and access and all of those other things.
David, is that a hand up? Yeah,
It-
okay, go ahead.
It is. I mean, I'm at this point using a KN95 and no issues with it in terms of wearing it for a long time. When I'm in hospital now, I wear my own mask because the hospital gives you these floppy little surgical masks to wear. One of the fascinating things in terms of watching this, this huge volume of research that's been generated over the last year is how quickly we've had proof of concept that these things really do work. And I have to defer to you and Paul and Jeff as people who really are experts in masks and ventilation at a level that I'll never attain. But what I will say is that when folks have done studies properly, and there's a really good study done recently at the Cambridge University teaching hospitals, where they were testing healthcare workers very regularly, so able to identify both symptomatic and asymptomatic infection via weekly tests. What they had there was they had a COVID ward. They had patients either go to a COVID ward or elsewhere in the hospital, and they were wearing surgical masks in both. And what they could see is that on the COVID ward, the relative risk of COVID in the healthcare workers was 50-fold higher than on the non-COVID ward. And the risk among healthcare workers on the non-COVID ward was the same as the risk in the community. They switched over to FFP3s, which I guess are sort of N95 more or less equivalent, and the risks equalized. It's like it's this remarkable proof of concept that filtering this crap out actually protects you, and they weren't putting those on the patients. So I think filtration is valuable. I agree with you. It's bidirectional, and people haven't gotten that. My mask protects you, your mask protects me, etc. The other remarkable piece of proof of concept, and I mean we're still kind of what's the word, Ouroborean, when something's eating its tail. It's still got this Ouroborean idiocy going on around aerosols versus big droplets and what have you with some of the folks who are really calling the shots in infection control. We have proof of concept on airborne transmission and the importance of ventilation from a Georgia school study 5 or 6 months ago, where the CDC was able to look at schools in the state of Georgia. And if you have HEPA air cleaners in the classroom and you improve ventilation, what improved ventilation is, if you read the papers, they open windows and doors. That's the ventilation improvement. This isn't ripping things out of the ceiling and replacing them. So that reduces transmission by 50%. And then adding masks reduces transmission by another 30%. So you got about 80% reduction in risk within a classroom by doing these very simple, straightforward things that would do absolutely, to use the technical term, bubkiss, if this wasn't an aerosol transmitted disease, because HEPA air cleaners don't do anything to big droplets that splatter. They do stuff to aerosols, as does ventilation. So we know how to do this. And to go back to the reproduction number, that's all about tipping points. A reproduction number, once it's greater than 1, you're into exponential growth, you're into outbreaks. If it's less than 1, the disease dead ends out and goes away. So if you're starting with a reproduction number that via vaccination, Delta has a basic reproduction number of, let's say, 8 to make the math easy, but 75% of the population is immune via vaccination. Now you've reduced that reproduction number to 2. Right? 75% of 8 is 2. So now you come along with ventilation and masks and some HEPA air cleaners, you reduce that 2 by 80%, you're now down well below 1, and the virus has nowhere to go. So again, feel like I'm repeating myself, but just to come back to the Swiss cheese model, when you use these things, they actually really do protect people in a multiplicative manner. So you do need all the different layers, but if you have all those different layers, you can keep people safe. But it's not on us. I think Jeff sort of mentioned, you can't reason with a virus. You can't sit it down and say, now look here, my good chap. we're prepared to do the masks and the vaccines, but we really can't limit class sizes. The virus doesn't care. And what you want to do is get from here to Christmas without outbreaks on campus, without people getting sickened, and without people, going to hospital and potentially dying. And how you get from here to there is very simple and very straightforward. So I think we've done part of it, but I'm very grateful to all the university faculty associations that you're continuing to push, because you need the whole package. You can't just pick and choose. It's not a la carte, right? Some very great.
And David, on that, I'm going to actually go full circle, but I want to bring Arjumand into the conversation, and then Ross, and then you, because part of what I've thought was fascinating was you've obviously been a significant public force encouraging vaccinations. And we have a slowing rate, or we're kind of running out of those who are interested. And some of the people who've been most hesitant or most dissenting have been from groups that have been poorly served by the medical profession in the past, BIPOC people, Black, Indigenous, people of color, and so on. I know Arjumand, when we talked about this before, was quite clear that it's also the case that the most vulnerable people, socioeconomically, racially, and otherwise, also have the most to lose from getting COVID. So I'm wondering whether the equity measures we need to take to ensure that everyone has real lived access to vaccines is actually here. And Arjumand, whether you think there continue to be barriers. I know, Ross, you're concerned that you, at least in conversations we've had in the past, that we have obligations that extend beyond mandating vaccines, or we need to be careful when we say we mandate those. And I, of course, want David to make the pitch for why it's one of the most unholy pieces of Swiss cheese to use vaccine mandates, if I can just bastardize that analogy completely. So Arjumand, have we done all we can to address populations who are not embracing vaccines for reasons that make a lot of sense historically and in terms of power relationships?
Yeah, it's a great question. If you look at the data from StatsCan, you actually see a really interesting age distribution as well. So it's not the case that all Black people are equally hesitant. You tend to see more hesitancy in young Black people than you do in older Black people who have a rate of acceptance that looks a lot like other non-white groups, and for that matter, in some cases, higher than white groups. And that is probably related, as you said, to distrust of a system that really hasn't served them, hasn't served their loved ones, combined with perhaps an age effect where they don't feel as vulnerable at this time, at least. And I'm going to say something really difficult, which is that it's very difficult at this moment when we need people to be vaccinated to all of a sudden now spring into action to make that happen, when historically people have been so underserved. And so when you disenfranchise people, when you discriminate against them, when you treat them poorly, it's very difficult to then call upon them in the moment that you need and all of a sudden scramble to make it all better. So one answer to your question is we haven't done enough, but another is that doing enough is really difficult, because that's what's, there's been, as you said, a historical legacy, both far history as well as contemporary history, and in the everyday lives of these folks, that has shown them that the healthcare system does not interact with them very well, that it's difficult to trust institutions for good reason. And it's a big jam of a problem. It's not an easy solution because it takes a lot to fix something that's accumulated over so much time.
And Arjumand, I keep thinking about the double-edged sword, the same groups that maybe are mistrustful and are vaccine hesitant because they're mistrustful are also quite likely to be more vulnerable, not just to getting sick, but also more vulnerable to efforts to produce enforcement or compliance around the other health and safety measures that are happening. So that's a tricky part. Ross,
That is
did you?
absolutely true.
Yeah. I'm not sure. I don't mean to cut you off. I'm wondering, Ross, if you wanted to also make a comment on the ethical obligations of those who want to produce vaccine mandates. And again, in this ridiculous context of a couple of minutes, what you
Yeah.
think our obligations might be.
Yeah, almost impossible to summarize within a minute. But so again, it goes back to the concept I alluded to earlier of reciprocity. If we are going to make mandates a requirement, what are the obligations of those making the requirements for the mandate to aid people to discharge their obligations to those mandates? So there's so the other thing is we really, why do we talk mandates? The language gets people's backs up to begin with. It's not a compulsion, and there's a lot of confusion. So we used to have, back in the day, in the 19th century, compulsory forcible vaccination. And in fact, an interesting historical diversion, which I don't have time to go through, but in a nutshell, the notion of conscientious objection was enshrined in British common law for refusal to compulsory vaccine. So we can debate the merits there, but Canada kind of followed suit in around 1905. So we need to sort of ask ourselves what we mean by mandatory: broad, wide, narrow. Cases for narrow mandates are probably stronger than for wide mandates. What do we mean by enforcement? I was interested to hear Mayor Tory say we have 200 bylaw officers at the City of Toronto, not 2,000, not 20,000. So the issue of the enforcement of the mandate becomes a very interesting one. And I fear, the fracturing of social solidarity that's already very shredded if we have sort of vigilante enforcement of mandates, and right now the default policy is to leave it at people, security guards at front lines, people at doors. So we need to really think clearly about this. And we also need to put a very clear and careful evaluation in place to assure that we've actually got net good coming out of this and not more harm than good. And I know many people may disagree with me on that, but it's irresponsible to put in major policies like this without a strong evaluative framework to figure out whether we're achieving the intended goals or not. I'm happy to come back and talk about this another time, but I think we're out of time.
I'm wishing madly for a whole piece on just the last part you said. Ashleigh, David, why is a vaccine mandate still a net good? Do you think it is? David is like, yes, go ahead, by all means.
I'm absolutely unapologetic about that. I think that there are things that we do from a societal point of view that we don't necessarily relish or jump up and down about, but that we do because we live in a society with other individuals, and it's part of coexisting and allowing society to function. And I think, paying taxes is something like that, and obeying laws that outlaw, felonies is part of that, and getting vaccinated in the midst of a virulent and destructive pandemic that's trashed our healthcare system and our economy for a year is part of that. The bar is the vaccine safe and is it effective? Yes, it is. It's very safe. Yes, it's highly effective. Does it prevent onward transmission? I've seen some comments in the question box. Yes, the vaccine absolutely does prevent onward transmission because we've known for about 6 months now that it prevents infection as well as disease. That's well documented in cohorts of healthcare workers. It's not only that you don't get disease, but you actually don't get infection. And we even know that in breakthrough infections, this is well studied in the Netherlands now, in breakthrough infections, vaccinated individuals who become infected are vastly less likely to transmit to people in their households. So the vaccine efficacy against onward transmission when the vaccine fails is 70%. So by being vaccinated, you're protecting yourself and you're also protecting other people in the midst of a public health crisis. I think it's very reasonable to require that people be vaccinated unless they have a compelling reason not to be. I think it's just a matter of, acting as a community and looking out for one another.
David, I agree with you, but I'm also persuaded that there are I'm shocked pleasantly by the huge consensus on university campuses of most of us, and the overwhelming majority of us, that we want vaccine mandates. I think part of what has been beautiful about this panel, and we're drawing to a close now, is that we've recognized that vaccines or high rates of vaccinations are a necessary but not sufficient precondition of our being able to safely reopen. At the same time, I'm also very mindful that for example, Colleen, who's the president of the Steelworkers, she has many members who don't want to get vaccinated, and those conversations are time-consuming and difficult conversations to have. And I'm looking forward to our figuring out how we can participate in having those respectful conversations, even when we differ so dramatically, because I, like you, think that getting really high rates of vaccination is a public good and the price of living in a society that's going to be able to move on from this. But I'm very, very conscious of the fact that Ross could probably make this argument significantly better than I can, and that we probably have to defer to another day. I'm going to turn to my trusty PowerPoint presentation for some very brief closing remarks. I'm going to share the screen and say, many of the questions that we received were not particularly scientific questions, they were political questions. Many of you asked, where do we go from here? Many of you asked, how can we refuse unsafe work? Each and every one of your faculty associations and unions will have follow-up emails. There are a number of different actions in place, including advice for people who believe that they're going to be in a position where they have to refuse unsafe work. I won't say much more about that. I'll stop and otherwise take the remaining few moments to thank profusely our outstanding panelists who have been fixtures on the health and safety scene in the province and nationally and beyond, who have been generous to the University of Toronto and now to all the universities in Toronto, and who I think are just both exceptional public intellectuals and damn fine people who give of their time. So please express your gratitude in the chat. Thank you very much to all our panelists and to our interpreters who have done an excellent job, and to all the people behind the scenes who helped make this very fine event happen. Thank you very much.